Okay, so this section is about COVID-19, and I want to go back a little bit and talk about some previous viral outbreaks because I think that you need to see the connections there. So in 2002, there was an outbreak of a respiratory disease, and it was named SARS, severe acute respiratory syndrome. And in 2012, there was an outbreak of a disease called MERS, Middle Eastern Respiratory Syndrome. And both of those were somewhat isolated. Both were caused by coronaviruses. And they both had symptoms that were anywhere from mild cold type symptoms all the way to fulminant respiratory failure. They also had other symptoms that involved the GI tract and the neurologic system and things like that. So there's a lot of similarities between those and SARS-CoV-2. So we had this precedent for these viruses, and there was concern at those times that we might have a pandemic type situation. In both cases, those outbreaks were kept very small, and there have been isolated cases here and there of those diseases, but those were kept very small. Now, in late 2019, there was another illness caused by a coronavirus that had similar symptoms and had people who went from relatively healthy to sick, dying of ARDS or respiratory distress syndrome. And they really didn't know what was going on. So they identified this virus as SARS-CoV-2. And you have lived through the rest of that story. That was first identified in late 2019. By early 2020, it was here in the US, and it's become a worldwide pandemic. So what caused this to become a pandemic when the two previous ones did not? And there's been some theorizing and some study about why, and some of it may have to do with human behavior, and some of it may have to do with viral behavior. SARS-CoV-2, or the COVID-19 virus, is a virus that is really well suited to transmission because it has a pretty long incubation. So people can be walking around for up to 2 weeks after exposure and be shedding the virus. And then when they first get sick, at least with the initial strain of this virus, when they first got sick, they might not be very sick until about day 5 to 7. And then some people around then would get better and some would get a lot worse. So that's almost 3 weeks of time to spread that disease because they're not sick enough to actually be confined to home. So that makes it a really, really easily transmitted, or it improves the rate of transmission. So the virus is still evolving. The virus that we have now, the variant that is actually being seen the most now, is different from the initial virus. And that's what happens with viruses. So it's still evolving, and the symptom profile, the transmissibility, the incubation, and the course of the illness varies. We have had variants that were much more transmissible than the initial. We have had variants that are a little bit less transmissible. We've had variants that seem to have less severe symptoms. So there's a lot of variation, and that's because the virus is evolving. So the patho of COVID-19, now it is believed to be, they believe it is likely an endothelial disorder. At first, we thought it was a respiratory disease because the most severe manifestations were respiratory. It probably does affect the respiratory system directly, but it also affects the vascular system quite a lot. And a lot of the respiratory symptoms are because of decreased perfusion because of those vascular changes. In severe cases, it causes ARDS, acute respiratory distress syndrome, and cytokine storm. So that brings another piece of it. The severity of this disease has to do with the immune response that it triggers. It triggers this inflammatory response that then sustains itself and can't be stopped. There's a potential for lasting damage to lung tissue, either because of inflammation or if that patient's on a ventilator because of high pressure ventilation. It also affects other systems. It causes GI symptoms for some patients. It's caused renal failure. Well, when you think about the perfusion issue, that makes sense, right? And it causes cardiac complications. Quite a few people have been left with cardiac changes. The incubation in the initial strain was 2 to 14 days with a mild prodrome. That seems to have shortened some with later variants, but it still possibly could incubate up to that long. And then the prodrome seems to have changed a bit with some of the later variants. Elderly and immunocompromised patients seem to be at the greatest risk for severe disease, but it's not extremely predictable because there have been healthy people who developed severe disease. There also are patients who recovered from COVID, some of whom had very mild cases, who have identified a set of symptoms that they're calling long COVID or post-COVID syndrome, and there's symptoms in pretty much every body system. So there are people who have some disability after a COVID infection, even if their case was mild, and they don't really know why yet. So that's all still under investigation. And then we've been through several variants, and every time there's a new one, we're all trying to find out, is this one more severe? Is this one less severe? Is it more contagious, less contagious? What does it do? What do the symptoms look like? With the initial virus, one of the hallmark symptoms for a lot of people was loss of the sense of smell and taste, and later variants have had less. That's happened less frequently. So remember those symptoms change. So signs and symptoms can range from mild to fatal. Typically we see fever, we may see a cough, chills and tremors, muscle pain, headache, sore throat. Loss of smell and taste was present with the early variants. We see less of that now than we did. Shortness of breath. And one thing with the initial virus and with, in particular, the Delta variant, was that patients would be very hypoxic, more hypoxic than their symptoms indicated. They called it happy hypoxia because the patient would be like, oh, I'm fine, and their sats are like 40. So that's the kind of the constellation of symptoms we're seeing. With some of the later variants, we've seen more GI symptoms, for example. Medical management is mostly supportive. There are now some treatments that have been approved, but it's mostly supportive. Proning has been shown to be beneficial, and proning has been used in ARDS for a long time. Oxygen support and ventilatory support. And we moved, initially they were intubating everybody, and then they considered using BiPAP, but they didn't want to use BiPAP because that spreads more virus in the air. And so they increased intubation again. They skipped over that BiPAP, CPAP step. But intubation has been associated with worse outcomes. Now, it's not clear whether that's because intubation itself is making those outcomes worse or because the patients who require intubation are sicker. And so they've moved away from intubation unless there's just not another option. And so now what we've seen more of is high flow nasal cannula and BiPAP. Okay. Some places are not using BiPAP because of the spread of aerosols, but be aware, high flow nasal cannula and BiPAP. ECMO is also sometimes used. If they just cannot oxygenate with the lung tissue, then sometimes they're on ECMO. So some treatments that have been effective, that's all supportive care. Some treatments that have been used, remdesivir, and there's been not controversy, there's been some conflicting evidence. It has been shown to be effective, but it also has been shown to have some side effects. So we've kind of seen phases in what's used, but remdesivir is definitely still on the list of treatments. Monoclonal antibodies have emergency use authorization. There are oral antivirals that have just come out recently that also have emergency use authorization. So I want to talk about emergency use authorization from the FDA. Normally, to get new meds approved, It takes years of going through the FDA process. They have something called emergency use authorization that they will expedite that process and do we're going to use this because it's an emergency. Right now, it looks like it's safe and effective, and the research is ongoing. And that's so that we don't have years of research with people dying when we have something that appears to be safe and can treat them. So monoclonal antibodies and oral antivirals are still under emergency use authorization. Now, there are a couple of old meds that have been proposed and have been researched as therapies. Hydroxychloroquine and ivermectin have not shown benefit, and they've done multiple studies on those. So you'll still hear patients talk about those, but neither one has been shown to be effective. Nursing care for this is supportive, and lots of infection control. Okay, we have relearned how to use PPE in the COVID pandemic. And then there are now vaccines available. Okay, in the next section, we're going to start talking about respiratory emergencies.